Hello guys, multiple births and its complication is my today's lesson. First of all, let us see the difference between monozygotic and dizygotic twins. Identifying twins as monozygotic or dizygotic is useful in determining the relative influence of heredity and environment on human development and disease. The previous assumption that twins not of the same gender are dizygotic can no longer be held as true. Sex discordances, placentation, and determination of amniosity and chorionicity are no reliable ways of determining zygosity. Detailed blood typing, gene analysis, or tissue or human leukocyte antigen typing can be used for zygosity testing. Physical and cognitive difference can still happen or exist between monozygotic twins because of other factors. The in utero environment may have been different, and also difference might exist in the mitochondrial genome, in the post-translational gene product modification, and in the epigenetic modification of nuclear genes in response to environmental factors. The other is about examination of placenta. If the placenta are separate, twins are dichoronic, but not necessarily dizygotic. 1/3 of monozygotic twins are dichoronic and diamniotic. An apparently single placenta may be present with either monozygotic or dizygotic twins, but inspection of dizygotic placenta usually reveals each twin has a separate codon that crosses the placenta between the attachment of the chordis and the two amnions. Separate or fused dichoronic placentas may be disproportionate in size. The fetus attached to the smaller placenta or the smaller portion of the placenta is usually smaller than its twin or it is malformed. Monochorionic twins are usually diamniotic and the placenta is usually a single mass. When we see the incidence of twins, difference in the incidence of twins worldwide mainly involves dizygotic twins. The incidence of monozygotic twins is unaffected by racial or familial factors. It is around 3 to 5 per 1,000 live births. Increases in monozygotic and dizygotic twinning have been associated with advanced maternal age and the use of assisted reproductive technologies. The use of single embryo transfer in assisted reproductive technology has decreased the number of triplet births and higher order births. The incidence of dizygotic gestation is also increasing, attributed to the treatment of fertility with ovarian stimulants. When we see the etiology, polyovular pregnancy are more frequently beyond the second pregnancy in older women and in families with history of dizygotic twins. They may result from simultaneous maturation of multiple ovarian follicles, but follicles containing two ova have also been described as a genetic trait leading to twin pregnancies. Twin-prone women have higher levels of gonadotropin compared to non-twin prone women. The occurrence of monozygotic twins appear to be independent of heritable factors. The etiology of monozygotic twinning is unknown, but there are two prevailing theories. The first one is the classic fission theory. Twinning results from the splitting of a single conceptus with the timing of splitting resulting in different amniosity and chorionicity. That means the earlier the fission occurs, the more likely the twins are to be diamniotic dichoronic. However, this theory fails to account for several forms of atypical twinning, including the occurrence of diamniotic dichoronic monozygotic twinning after single embryo transfer in the late blastocyte state, and also phenotypically discordant monozygotic twins and asymmetrically attached conjoined twins. The alternate fusion theory of twinning has been proposed to account for this discrepancy, and this theory says the inner cell mass of trophectoderm fuse after the initial two-cell splitting stage. The other issues about atypical twinning. Conjoined twins are obligate monozygotes, and conjoined twins occur 1 in 250 live births. Theoretically, they result from later fusion of a single zygote around 10 to 14 days or from fusion of two zygotes as proposed for asymmetrically attached conjoined twins. The majority of conjoined twins are female, and the prognosis for symmetrically conjoined twins depends on the possibility of surgical separations, which in turn depends on the extent to which vital organs are shared. The site of connection varies, and most of the time it is at thoracomphalophagus around 28%, thoracomphagus around 18%, omphalophagus around 10%, cranophagus around 6%, and incomplete duplication. Thoracomphalophagus means attachment at thorax and at the abdomen, whereas thoracomphagus is at the abdomen, omphalophagus is at the abdomen, and cranophagus is at the head. The other is about the issue of parasitic twin. Parasitic twin means if the embryonic demise occurs in utero but that remains vascularized by the surviving independent twin or the oocyte. For asymmetrically attached conjoined twins, in whom one twin is dependent on the cardiovascular system of the intact oocyte, or that means exoparasitic twins, survival of the oocyte depends on the feasibility of exceeding the exoparasitic twin. For endoparasitic twins, which means fetus in feto, in whom one fetus exists as a benign mass in the oocyte, survival of the oocyte is unaffected. When we see complications of twins, problems of twin gestation include, for the mother, polyhydramnios, hyperemesis gravidarum, preeclampsia, premature rupture of membrane, vasa previa, velamentous insertion of the umbilical cord, abnormal presentation like breech, premature labor, and the like. Monoamniotic twins have a high fatality rate because of obstruction of the circulation secondary to intervening of the umbilical cords. Compared with the first-born twin, the second twin is at increased risk for respiratory distress syndrome and asphyxia. When we see the impact of being a twin on the newborns, it can cause intrauterine growth restriction, twin-twin transfusion syndrome, or congenital anomalies, which occur predominantly in monozygotic twins. Anomalies are as a result of either compression deformation of the uterus from crowding, like hip dislocation, or it might be due to vascular communication with embolization, like ileal atresia, fetus aplasia, or vascular communication without embolization, like acardiac twin. And also anomalies might be unknown factors, like anencephaly and meningomyelocele. When we see twin syndromes means twin reversed arterial perfusion and twin-twin transfusion syndrome. Placental vascular anastomoses occur with high frequency in monochorionic twins. They are usually balanced so that neither twin suffers. Artery-to-artery communications cross over placental veins, and when anastomoses are present, blood can readily be stroked from one fetal vascular bed to the other. Vein-to-vein communications are similarly recognized but are less common. A combination of artery-to-artery and vein-to-vein anastomosis is associated with the condition of acardiac fetus. These rare lethal anomalies, which occurs 1 in 35,000, is secondary to the twin reversed arterial perfusion syndrome. In rare cases, one umbilical cord might arise from the other after leaving the placenta, and the twin attached to the secondary cord usually is malformed or dies in utero. In twin-twin transfusion syndrome, an artery from one twin acutely or chronically delivers blood that is drained into the vein of the other. The latter develops polyhydramnios, plethoric, large chordates, and the former has oligohydramnios, anemic, and small. Twin-twin transfusion syndrome is more common in monozygotic twins, and it affects up to 30% of monochorionic twins. Maternal polyhydramnios in a twin pregnancy suggests twin-twin transfusion syndrome. Anticipating this possibility by preparing to transfuse the donor twin or to bleed the recipient twin might be life-saving. Death of the donor twin in utero might result in generalized fibrin thrombi in the smaller arterioles of the recipient twin, possibly as a result of transfusion of thromboplastin-rich blood from the macerating donor fetus. Disseminated intravascular coagulation might develop in the surviving twin. Treatment of these highly lethal problems include maternal digoxin, aggressive amino reduction for polyhydramnios, selective twin termination, or more often, laser or fetoscopic ablation of anastomosis. When we see the complication on both the donor and the recipient on twin-twin transfusion, most of the time the donor is small, premature, malnourished, pale, anemic, hypovolemic, hypoglycemic, have microcardia, glomerulus small or normal, and arterioles are thin-walled, whereas the recipient one is having large premature, well-nourished, plethoric, polycythemic, hypervolemic, cardiac hypertrophy, and they might have tricuspid valve regurgitation, right ventricular outflow obstruction, and large glomerulus, and both of them are premature. When we see the diagnosis of twin pregnancy and delivery, a prenatal diagnosis of pregnancy with twins is suggested by uterine size that is greater than that expected for gestational age, and also auscultation of two fetal erythrocytes and elevated maternal serum alpha fetoprotein and beta-HCG levels. It is confirmed by ultrasonography most of the time, and the physical examinations of twins is necessary but not sufficient to determine zygosity of twins. In the event that congenital anomalies are present or there are transfusion or transplantation consideration, genetic testing for zygosity should be performed. Regarding prognosis, most twins are born prematurely, and the maternal complications of pregnancy are more common than with single pregnancies. The risk for twins is most often associated with twin-twin transfusion, assisted reproductive technology, and early onset discordant growth. Because most twins are premature, their overall mortality is higher than that of single birth infantes. The perinatal mortality of twins is about 4 times that of singletons, with monochorionic twins being particularly at risk. Monoamniotic twins have an increased likelihood of cord entanglement, which may lead to asphyxia. Twins are at greater risk for congenital malformations, with up to 25% of monozygotic twins being affected. Theoretically, the second twin is more subjected to asphyxia or anoxia than the first. This is because the first one is the placenta might separate after birth of the first twin and before birth of the second twin. And also delivery of the second twin might be difficult because it might be an abnormal presentation like breech, cord entanglement, and also uterine autonomy might be decreased. The cervix might begin to close after the delivery of the first twin and before the delivery of the second twin. So due to all those reasons, the second twin is more at risk for having perinatal asphyxia than the first. Triplet or higher order births are associated with increased risk of death or neurodevelopmental impairment compared with extremely low birth weight singleton and twin infants after controlling for gestational age. Because of this poor prognosis, selective fetal reduction has been offered as a treatment option. Monozygotic twins have an increased risk of one twin dying in utero. The surviving twin has a greater risk for cerebral palsy and other neurodevelopmental sequelae. When we see about the treatment, perinatal diagnosis enables the obstetrician and the pediatrician to anticipate the birth of infants who are at high risk because of twinning. The risk of multiple gestation pregnancy using assisted reproductive technology might be reduced by elective single embryo transfers. In addition, elective delivery of twins at 7 weeks or earlier for monochorionic monoamniotic twins reduce the complication rate for the fetus and the mother. Furthermore, in twin pregnancies between 32 to 39 weeks of gestation, planned vaginal delivery is preferred if the first twin is in the cephalic presentation. Close observation and attendance by a pediatric team are indicated in the immediate neonatal period so that prompt treatment of asphyxia or fetal transfusion syndrome can be initiated. The decision to perform an immediate blood transfusion in a severely anemic donor twin or partial exchange transfusion of recipient twin must be based on clinical judgment. This is what I have for twin deliveries and its complication. Thank you for listening.